thing that we do see when people have surgeries or even any kind of health problem, especially at older ages, is the risk of delirium, which is a type of confusion that'll happen suddenly. So it's a sudden onset thing as opposed to the gradual onset of dementia. And we hope that that's a reversible thing, so that as someone comes out of the surgery or the infection or whatever they've got going on, that they'll improve. We know now from better research that they don't always get back to the exact baseline that they were at before. So we can have a cumulative effect of that type of thing. Repeated episodes of delirium can certainly predispose someone to having worse cognition and function. And we're not sure exactly why or how it works that the accumulation of other seemingly unrelated problems predisposes to dementia, other than to say that we're all connected together. Our whole body is one, and we need to have a better unified focus as opposed to focusing on specific organ systems. So polypharmacy means taking multiple medications, too many medications, or also inappropriate medications that have interactions with one another or with other medical conditions you have. And certainly a lot of seniors are on many medications. And there are a lot of medications that can have harmful effects for memory, thinking, mobility, and cause falls and whatnot. So one of the key things we do as part of our comprehensive assessments, as I mentioned there, is go through the medical conditions somebody has and the medications they have, and try to get rid of medications that they don't need, or wean things down over time. Because a shocking number of seniors, especially senior women actually, are on medications that aren't ideal for the longer term. Things like tranquilizers, benzodiazepines, sleeping pills. And we need to work about educating people that they shouldn't be on them for a long time, and that educating physicians who prescribe them in the first place that they shouldn't rely on those types of things, because they can be very harmful. And we do see that people can have improvements in memory and function if we get them off these medications. So it's a key issue, I agree, and it's one that the CCNA, the big project, is going to be well positioned to address. We have a specific team there focusing on Indigenous health issues and cognition, for example. The studies that have tended to be done in the past, have had in Canada at least, have had a very small proportion of cultural minority communities represented, but we're improving that now. So the studies that are being done now are aiming to recruit and include more people from different backgrounds. So I think we will be finding out a lot more about that in the future. Cultural expectations can be different too, and so sometimes families will normalize something that really is outside the realm of usual aging. Or the reverse, right? So, and we have to do a better job of understanding how somebody's cultural background will impact on that. Sure. So the exercise recommendations for everybody, and it's a matter of finding some exercise that's comfortable and possible to do within one's own limitations. So I know for the issue around arthritis, like the Arthritis Society actually maintains an excellent list of exercise classes and opportunities for seniors that are relevant to people who have arthritis. And we actually use that more generally to recommend to frail people because it's somewhat of a similar, some overlapping concerns. And things like aquasize, so low impact, might be better for people who have trouble with their knees, that type of thing. Really, exercise is a cornerstone, and it's a matter of trying to figure out what'll work for the person. So where possible, we often recommend having an assessment with a physiotherapist who has some expertise in the area, or a trainer kind of person who has the expertise with seniors, to make sure that somebody's doing exercises that are safe for them and sustainable.